Welcome to this revision deep dive. Both of us are plastic surgeons, and, well, today's mission is high-yield revision on upper and lower back contouring.
Right, and we're tailoring this directly to you, the resident listening right now, preparing for your board exams, specifically the FRCS in plastic surgery.
Exactly. We are skipping the fluff and getting straight into it. But before we start the questions, if you're studying for the boards, head to medsynclimited.com and get the FRCS Plastic Surgery Anki Deck.
Yeah, you really need to check that out. It has like over 6,000 questions arranged by topic to help you recall key facts.
And it's all based on the textbook keynotes in plastic surgery. Also, make sure to hit follow on the show to get more of these revision deep dives. And, please rate it if you learned something today.
Absolutely. So, ready to dive into the clinical material?
Yeah, let's do it. Okay, let's unpack this, starting at the top. For the exam, what are the primary indications for an upper back lift?
Well, the primary indication is managing severe excess skin following massive weight loss or, sometimes following extensive liposuction where the tissue it simply fails to retract.
Right. The skin envelope is permanently expanded. And what about the classic combination procedures? Examiners love asking about those.
Oh, they definitely do. You are rarely just addressing the upper back in a vacuum. So you need to know it's frequently combined with a reverse abdominoplasty.
Okay.
Or it can be combined with a mastopexy and a brachioplasty.
Right, because you have this continuous roll of redundant tissue. But I want to zero in on something from our revision material today that represents, honestly, just brilliant surgical engineering.
The breast combinations.
Yeah. In that combination with breastwork, we aren't just discarding the upper back tissue. We're talking about auto-augmentation of the breasts. It's like a master carpenter repurposing offcuts.
That is a perfect way to look at it. This is a crucial concept for the boards. Instead of throwing that excess sin and fat in the pathology bucket, you use dermal fat flaps.
Wait, really? You just slide it around?
Yeah. You maintain the vascular attachment of a specifically designed flap of this redundant tissue, mobilize it anteriorly, and use it to auto-augment the breasts.
That's incredible. We are taking tissue that's a burden in one zone and using it to correct a massive volume deficit in another. But technically speaking, how do we prep that tissue?
Well, obviously, you can't just bury skin. You have to de-epithelialize the portion of the flap that will be buried.
Right.
You carefully shave off the epidermis, leaving the dermis and the underlying subcutaneous fat intact. The fat provides the autologous volume, and, you're preserving its native blood supply.
Which avoids all the long-term complications of implants. That is such a high-yield concept. So let's move to the prep room. The patient is awake. We need to do our preoperative markings.
Okay. First and foremost, and do not let the examiner catch you slipping on this, the markings must be done preoperatively with the patient in the standing position.
Always standing. I mean, why is standing an absolute non-negotiable rule here?
Because gravity is the ultimate dictator of the final result. Once a massive weight loss patient is lying down, whether prone or supine, their tissue completely shifts.
Oh, right. The tension lines just disappear.
Exactly. If you mark them lying down, you will almost certainly underestimate the excision volume, or you'll misplace your final scar entirely. Standing is the only way to see the true extent of the redundancy.
Okay, so they're standing. What is our actual pentaskin design?
You're drawing two transverse lines to mark your estimated excision. In female patients, the placement of these lines is critical. The final closure should be centered exactly on the bra line.
To hide the scar.
Right. And those transverse lines don't just stop abruptly, they taper anteriorly into the chest or to seamlessly meet your reverse abdominoplasty markings.
Got it.
And finally, before they lie down, you must add vertical crosshatches across your upper and lower lines.
Yeah, let's emphasize the crosshatches, because once you undermine that tissue, it becomes incredibly mobile.
It really does.
If you don't have those hash marks to force you to align point A to point B, you risk a shift in closure and massive dog ears.
They are your absolute roadmap when everything else looks like a blank canvas.
All right, so the patient is marked, anesthetized, and we're moving to the OR. Let's trace the actual sequence. Positioning.
The patient is placed in the prone position.
Okay, here's a targeted exam question. Which incision is made first, and why does it matter?
What's fascinating here is that the sequence is entirely dictated by safety and tension control. You make the upper incision first.
Just the upper one. Why not cut both lines right away?
Because those pre-op marks are just an estimation. If you incise both immediately, you completely commit yourself to that exact width.
Ah,
If you overestimated, you suddenly have a massive defect. You can't close without catastrophic tension. So you make the upper incision first, perform your undermining just above the deep fascia, and elevate the flap.
right, and then you pull it down.
Exactly. You physically pull it downward over your lower marking. Only then, after estimating how much skin overlaps, do you make your lower incision.
Dynamic estimation, I love that. So we've excised the redundant tissue. Now we have a large undermined defect. What about closure mechanics?
First, place surgical drains. You just created a massive dead space. After drains, the closure must be meticulously layered to reestablish the continuity of the SFS.
The superficial fascial system. Why can't I just use some heavy dermal sutures?
Because the skin undergoes constant creep under tension, that scar will stretch out beautifully in 3 weeks. The SFS is the true load-bearing structure. Meticulously suturing it transfers tension away from the skin.
The SFS does all the heavy lifting. Okay, so how do we wrap up the upper back?
The patient must be turned supine. This allows you to safely complete the excision onto the lateral chest.
All right, that thoroughly wraps the upper back. But let's move down. Once we've contoured up top, gravity is relentless, right? What else is addressed during a lower back lift besides just the hanging skin?
Well, there's a severe functional issue. You have profound volume loss in the buttocks, which causes real pain on sitting.
Because they've lost that adipose cushion over the sitting bones.
Exactly. So the lower back lift is a reconstructive opportunity, and it's often combined with liposuction of saddlebags over the trochanters.
Here's where it gets really interesting. The markings. It's a much more complex shape down here, right?
Yeah, again, the patient is standing. You use a skin pinch test to determine the two transverse lines,
Okay.
but they take on a gull wing configuration. They have an inferior inclination towards the natal cleft.
A gull wing. Why not just a straight horizontal line?
Because a straight line would obliterate the natural curves of the body. The gull wing expertly delineates the aesthetic subunits of the buttocks.
It respects the natural V shape.
Exactly. And laterally, they taper anteriorly into the lateral abdomen, or they meet an abdominoplasty or medial thigh lift. But here is the vital planning step.
What's that?
You must design 2 medially based flaps right between your planned excision lines. These are specifically for buttock auto-augmentation.
It really is incredible. You have the problem deflated buttocks and the solution excess back tissue sitting right next to each other. Let's walk through the physical operation. We're prone again.
Yes, starting prone. And here's a key exam point. If you planned any liposuction, it must be done prior to excision.
Wait, why? Couldn't I just elevate the flap and lipo under direct vision?
Absolutely not. Liposuction aggressively alters the vascular network. If you elevate the flaps and then aggressively lipo, you risk avulsing the perforators. You'll cause flap necrosis.
Right, that makes physiological sense.
Plus, lipo removes volume, which changes how much skin you actually need to cut.
Secure the volume first. Got it. So lipo is done. We make our upper incision first. How do we handle those 2 medially based flaps for the auto-augmentation?
First, they must be completely deepithelialized. Every trace of the epidermis must be removed. Then, you undermine superficial to the lumbar and gluteal fascia. But here is the most critical warning. You must preserve a pedicle for those buttock augmentation flaps.
Right, the medially based pedicle.
Yeah. If we connect this to the bigger picture, preserving that pedicle is the only thing ensuring the viability of the auto-augmentation. If you sever it, you just created a massive free graft that will likely necrose.
You have to dissect around it. So how do we physically get them into position to pad the sitting bones?
You create deep subcutaneous pockets inferiorly. Then you transpose the flaps, essentially folding them downward on their hinge into the pockets and suturing them to the deep fascia.
And then closure.
Right. You estimate the skin removal, make your lower incision, and advance the inferior backlift flap over the augmentation flaps. Meticulous layered closure, then turn them supine to finish.
So what does this all mean? For you listening, upper and lower back lifts aren't just about skin excision. There are highly engineered procedures focused on tissue repurposing and restoring functional anatomy, like alleviating that pain on sitting.
It is pure surgical architecture. You're rebuilding the foundation. And I want to leave you with a final thought to mull over for your exams.
Oh, perfect. Lay it on us.
Consider the biomechanical tension placed on the superficial fascial system, the SFS, when a patient transitions from the prone surgical position back to standing.
Oh, wow. That is a massive shift in gravity.
It really is. Think about how meticulous layered closure is the only thing standing between a beautiful contour and a horribly widened scar.
That is an excellent point to ponder. Well, if you have a comment or a question about this material, please leave it below the track. We read all of them.
We absolutely do.
And remember to rate this deep dive and check out the MedSync Anki deck to lock in these facts for your FRCS exam. Keep studying, and we will see you on the next deep dive.